All right, it's time for us to do our Kegel exercises. Why do we do them? Who cares? Well, the reason is that our pelvic floors are very important for our health. Our pelvic floors hold up the organs of the pelvis, including in women, the uterus, the vagina, the bladder, and the rectum. And so the stronger you can make your pelvic floor muscles, the better you can support them.
I like it. So then we have this patented GynoCast customized Kegel exercise. World-renowned custom.
And acclaimed. Prized-winning.
We sound super fancy when we talk about it like that.
That's right.
But you've come up with this great routine that we can use to help strengthen our pelvic floor.
So easy.
Right. So you ready to start it off?
I'm ready.
Okay. 3
times a day.
6
days a week.
9
seconds per Kegel exercise.
And 12.
Kegel exercise in a row for a rep. And so you're just doing it 3 times a day. Do 12. Hold it for 9 seconds. Okay, you can do it 6 days a week and take a day off. You'll have a pelvic floor like a chain link fence, Twila Dang.
I like
You'll
it.
be able to pull a trailer. You will be the envy of your neighborhood. You will walk taller.
I'm going to go do them right now. I'd like to walk taller today. So make sure that you're doing them, and feel free to go get that infographic off of the GynoCast Facebook page and share it with your friends as well. Stay tuned.
Hello, everyone, and welcome back to the GynoCast. My name is Dr. Eric Heegaard. I'm a board-certified obstetrician gynecologist. I'm sitting here with my favorite vegan.
I'm Twila Dang.
And you are listening.
I'm just going to get a T-shirt now that says your favorite vegan.
That's right. And for those of you who are new to the GynoCast, welcome aboard. We love getting new listeners, and please join our little GynoCast family, which is growing.
Please do.
And why do we care? Because as we've talked about before on this show, is that even if you are, okay, let's just say a total dink. Let's say you're a total dink, right?
No.
You don't care about anything except yourself.
No.
Well, let's just say we need to include those people too. But if you care about nothing but yourself, Twila, you'll care about making it a better world, because if it's a better world, it'll be better for you, right? And we know that educating girls and women make for better families, make better cities and towns and communities and countries, and a better world and a better universe. And that's what we're all about. We're trying to move this world forward to make a better place. How do you like that? Is that a big enough vision?
It is.
All right. So
I like it.
So those of you who are new, welcome aboard. Join our family. Those of you who have listened before and decided, hey, that was pretty good, I'm coming back. Welcome back, and thank you for joining us. Now, if you're not a member of the GynoCast Facebook group, Twila, what should they do?
They need to go to Facebook. Go in the search bar and type in the GynoCast.
The GynoCast.
GYNOCA. Don't do that. I'm spelling now.
C-A-S-T.
Stop that so they can hear me.
We're a little low tech here, so I'm trying to add some.
No, we're not. We're decidedly low tech. We don't need all those sound effects right now.
That's the only other. That's the only side. That's the only other sound effect.
I'm glad that you're enjoying yourself.
All right, I'm in a mood.
If you go to Facebook and type in GYNOCAST, it'll bring you to our Facebook page. You have to ask to be a member. We don't just let everybody in. We have sensitive conversations, but respectful conversations about sensitive topics, and we want to make sure that the people that are involved with those conversations are there for the right reasons. So don't worry, it takes almost no time to get you vetted and in there, and then you can have discussions with us. You can send emails to the show. You can share information. You can post topics for future episodes. We actually just recently you asked.
I did.
You asked our members about future topics.
That's right.
And we got a lot of really great responses.
Yep.
So we love that kind of sharing and exchange in the Facebook group. So make sure you go to Facebook and join the GynoCast Facebook page soon.
That's right. And so on the GynoCast, we talk about everything and anything. I'm taking your words now. Anything and anything women's health.
Anything and everything.
What did I say? Anything and anything?
Uh-huh.
Everything and anything.
You are doing it so poorly today.
I
we talk about anything and everything, women's emotional and physical health and well-being.
That's right. We talk about things that people need to know about, want to know about, but sometimes don't know where to go. Well, the place to go is here, the GynoCast. So don't Google GynoCast. Oh
boy.
Okay, so today we are talking about a subject, and I'm going to have you guess what it is, Twila, because I'm going to give you a little historical background.
Go for it. I'm
okay.
ready.
So just let me read a few of these and then see if you can jump out. But don't, because I don't want you, if you jump out with the answer too soon.
I won't. I'll play along.
Okay. So using radiographic technique, The Egyptology Department of the English Museum in London detected calcified pelvic masses and mummies, which were suggestive of blank. So we're talking about Egypt. The ancient Greeks were also aware of this condition, with Hippocrates, 460 to 375 BC, referring to these as uterine stones. Huh. In the 2nd century of the Christian era, Galen described these as scleromas. In medieval texts referred to women who used to expel bird eggs from their vaginas. Bird eggs? Okay. Let me give you a hint. They weren't bird eggs.
I figured.
These texts were likely referring to blank.
Ooh. Can I answer now?
Ooh, yeah.
Fibroids.
You got it. Uterine fibroids, otherwise known in the medical terminology as myomas, fibromyomas. And I think most people probably have heard of them. They are benign, smooth muscle tumors of the uterus, and they're incredibly common, ranging anywhere from, depending on what study you're looking at, 20 to 50% of women have fibroids, and they're
really
not
20 to 50%.
Yeah,
really,
yeah,
really.
All right, let's say 10 to 50.
And I guess I
feeling
just
the pressure,
felt like
right?
That was that was
You're acting
more
like
of,
you don't believe me.
No, I do believe you. I'm actually just surprised that I didn't realize the number was that high.
Yeah, it's incredibly common, and the reason why you don't know this is that most of the time they don't necessarily cause any problems, but sometimes they do, and that's what we're going to talk about today: is what they are, what problems they cause, how we evaluate them, and how we treat them. So this is a little bit more. Let's see. The first laparotomy, which means an incision in the abdomen, was performed in 1809 in Danville, United States. The surgeon...
Wait. That's in Virginia, right?
Yeah, in the United States, right?
I'm just saying it's in Virginia.
Yeah, but who cares?
Fine.
For those of you who don't know, Twila Dang is a Southern gal.
No, you're not pulling out the Colonel Sanders impression right now just because I'm from the South.
She was raised, you were not born, but you were raised in Virginia.
Deep, sad sigh.
And...
just get to talking.
Okay, so anyway, the surgeon Ephraim, that's not a name you hear very often. No. Ephraim McDowell performed the surgery on a Mrs. Jane Crawford, the cousin of somebody who will become president. That's right, Abraham Lincoln.
Oh.
It was thought that Miss Crawford was pregnant with twins. Well, it turns out she was not pregnant at all. And she didn't have twins. She had fibroids.
Whoa.
So that's when medicine was really exciting. When you had no idea what was going on.
That's kind of sad too. Let's just thought she was having babies, and she just giant fibroids.
Yeah, this was the perspective a long time ago, which is, let's cut open and see what it is.
Yeah, hello.
Yeah.
Wow.
So, it wasn't twins. It was a huge tumor, which on pathology showed it was a fibroid. So in 1840 in France, Dr. Jean Zolima Amusat performed the first intentional myomectomy, which means moving the actual
Wait, say that again. What is it called?
A myomectomy. Or in French, it's a myomectomy.
No, we didn't do all right.
A myomectomy, because they're myomas. Fibroids also called myomas.
Right.
Myomectomy to remove that. And so, so this has been going on for a while, but, for many years this was fraught with complications and a lot of blood loss.
Don't say.
Yeah. It's just like, you didn't want to get operated on before 1950.
Nah, it's okay.
And, it's, I shouldn't laugh, but anybody who was alive back then is dead.
Yeah.
Yeah, and it has nothing to do with whether they had surgery or not.
No, at first it sounded like anybody alive back then is dead.
That's right. So, now, this is great. In 1898, Alexander Adams presented 11 cases of myomectomy through an abdominal route. However, as the cases he were describing were much more complex than he had thought, it was not well received by the audience. Anyway, well, it's just it was a jungle, and medicine was a total jungle.
Yeah,
and he was not well received, and therefore the whole procedure kind of disappeared for like 50 years, at least in the literature.
Well, I mean, I can understand why, though.
This caused the myomectomy, the removal of just the fibroid, to be abandoned until 1922 when Victor Bonnet, or I should say Victor Bonnet, a British surgeon, invented the clamp for myomectomy as a way of decreasing intraoperative bleeding, which is good. By 1930, Bonnet had performed the myomectomy 403 times with very few fatalities.
Very few. Listen, very few is a victory.
But it's just, you don't, in modern day, surgeries, you don't, when you do surgeries for something that, you don't expect anybody to die.
Yeah, exactly.
Right. And so you don't say,
back then they were like, listen,
this was, you don't
it's
say,
just a handful, it's all good.
Yeah, exactly. This, you don't say, when you're presenting to a scientific group, well, I did a lot of these and really, really well, and we had, not very many people die.
Aces.
Yeah. So so when's lunch? I think we're breaking for lunch now. And so, so things have changed. So, the question is, why do we care? Why do we care about fibroids? Well, as a woman of color, Twila, you might know, or maybe not know, that fibroids are much more common in women of African Americans than Caucasian.
Yes.
Or Asian. Why? Nobody knows.
Oh, I thought you were going to have an answer to that. I was getting ready to say why.
Well, the thing is, I don't know. Can't pay too much for this kind of advice.
Yeah, hey,
heck, I don't know. Well, the thing is that it tends to run. It is genetic. It tends to run in families. So,
right.
If you have them, there's a good chance your mom or grandmother may have had it too. So it tends to run in families. And so, why are African American women more predisposed to them than women who are Caucasian or Asian? I don't know if anybody knows, but we'll find out. And that's when we're doing on the GynoCast. I'll tell you this: in 2021,
okay,
we'll have the answer to that.
Stay
tuned. Stay tuned. Listen to
big talk from the doctor over here. All right.
Stay tuned in the episode in 2021. We'll disclose this. But and Latinos tend to be a little bit more than whites, less than African Americans, and so it gets very complicated. But the point is that whether you're talking about white or African Americans, you're talking about 10 to 50% of women have these. And why don't we speak more about them? Well, oftentimes you can have them, and they don't cause any problems. You can actually have great big fibroids. And I remember I did an operation on, this may have been maybe 5 years ago, on a patient of mine who, in and of herself, is about 6'5". She's a giant of a woman. And she had a giant of a uterus. And that thing, I'll tell you, her uterus was the size of a watermelon, Twila. A watermelon.
What? No.
No, watermelon, not what?
No, really?
Watermelon.
Okay, why are you doing that?
I'm just messing with you. Because it's almost 4th of July, so it's watermelon time. So, but her uterus was and she'd been living, and finally she was bleeding so much, she just said, I got to get rid of this.
Yeah.
And the thing, it was massive. And so people can live with these things for many years without necessarily causing problems. However, probably 10% of women who have significant fibroids, and by that I mean over 4 or 5 centimeters, will have some symptoms. And what are those symptoms? Well, as you can imagine, men out there, can you imagine if your prostate was the size of a baseball? Well, you might feel some pressure on your bladder, So people who have masses in their pelvises can feel pressure sometimes on their bladder, sometimes pushing on their rectum. It can cause pain with intercourse, sometimes just pain. And so in those situations, you have to figure out what to do. It can also cause bleeding. Depending on where the fibroids are, they can cause heavy bleeding. Mm-hmm. And thirdly, it can cause issues sometimes with fertility, although most of the time not. And again, it kind of depends on where they're located. Now, we kind of define fibroids basically in regard to where they are located. So if you imagine the uterus, I'm going to jump into this again. I'm going to use my vegetable metaphors.
You have vegetable metaphors?
Yeah.
Okay.
I went from fruit to vegetables.
Okay.
Although I'm starting to think,
never
is an
mind.
avocado a fruit?
Yes, avocado is a fruit.
Is it really?
That's what I'm going with today.
Yeah. Okay. So we'll have to go in.
I should probably Google that.
I always get a little. It gets a little funny when I start thinking about the difference between fruits and vegetables. Aren't vegetables underground?
We're not doing all this. Just
Well,
make your analogy.
But peppers are not underground. Anyway, whatever. No, I think fruits have seeds. That's it.
Oh
Fruits
my
have
gosh.
seeds. Fruits have seeds. But don't peppers have seeds? Okay. Oh,
if you don't just make your analogy,
will you just
sir.
clarify this for me? My God. Oh, when we used to have a live show and somebody could actually call in and let us know. Will you look this up, please, for God's sake?
I'm already on it. Just keep talking.
Okay. So anyway, but imagine the uterus as a avocado, because that's about the size. A small avocado is about the size of a normal uterus. And if you take the pit out of the uterus or out of the avocado, you actually have something that is sort of looks like a uterus. You have a little hole.
Avocado is a fruit.
Yeah, but what is the difference between a fruit and a vegetable? That's what I'm trying to figure out.
Oh, heavens to Betsy. What is this?
But is a pepper a fruit because it's got seeds in it?
No, it's a vegetable.
Well, what is the definition of? Can you just please, for God's sake, I'm going to talk a little bit. Can you look it up so it doesn't drive us crazy? So, anyway, so fibroids. The question is, where are they located? If they're located on the outside, like growing like I don't know, like a little mushroom on top of your avocado on the outside of the wall, or basically kind of attached just to the outer edge, that's called a subserosal fibroid, or it can be pedunculated if it's really growing like on a stalk. But so those are fibroids that are on the outside. The next category is what we call intramural, which is inside the muscle, being composed or mostly invading into the muscular wall of the uterus. And then there's what we call submucosal, which is basically located on the inside of the uterine cavity. And so 3 different types, and how we approach treatment for those depends on where they are, and also if they're causing you problems and how big they are.
Okay.
Do you have the answer to the question?
Yes, I do.
What is it?
I was trying to avoid it. Okay, so according to the Google, your friend, my friend, our friend, it says, botanically speaking, a fruit is a seed-bearing structure that develops from the ovary of a flowering plant, whereas vegetables are all other plant parts, such as roots, leaves, and stems. This includes such botanical fruits as eggplants, bell peppers, so bell peppers are fruit, and tomatoes. So it turns out you were right. Look at you, twice in one day.
Well, just most of us don't think about peppers as being fruit. That's very interesting.
Well,
okay, so
we learn something new every day.
All right, so you learned something on the GynoCast, and so thank you for listening today. Please tune in. No, so again, the first question when you're trying to evaluate somebody with fibroids is it causing a problem?
Yes,
because and usually by the time if they come in to see us in clinic, it's usually because they have a problem.
And a lot of people now, is it true that a lot of people can have them and they don't cause a problem?
Yeah, exactly. You can have, like I was saying, that woman that I finally operated on with a huge watermelon-sized fibroid. She'd been having it for years and decades, and it wasn't bothering her that much. And depending on a person's size and the size of the fibroid, where it's located, people walk around with melon-sized fibroids. Melons being fruits, of course, because they have seeds. In their abdomen, it doesn't really bother them. So, again, people come in for a few reasons. They're either having pain or pressure, or they are bleeding. And that's one of the first things we look for.
So, is this pain and pressure or bleeding outside of, say, what happens during a period? Right. It's consistent,
right? Well, it can be,
sometimes it's just intermittent.
Yeah, it can be. Well, it can be all of those things. So, for example, let me just. So maybe it's a good idea to just talk about a typical patient. So a patient might come in. Actually, I saw somebody just a couple days ago whose blood count was like 5.
Well,
she'd been bleeding down to normal blood count. A hemoglobin is over 11 easily, and she had been, she had a hemoglobin of 5. And actually, she said, I was feeling a little tired, and she's about 40 years old. She came in. I was like, tired? My God.
Yeah, you're walking.
If she was 60, she'd been dead.
Oh, wow.
With that kind of hemoglobin, she would have had a heart attack. But she wasn't 60. She was 40 and pretty healthy. She just didn't have any blood. And so she went to the emergency room. They checked her blood count, and indeed, they found out it was 5. They went ahead and transfused her some blood to fill up the tank, and she felt much better. But now the question is, how do we evaluate it? Well, we're going to get an ultrasound, and on my examination, her uterus felt a little enlarged, and so I would imagine that she probably has a fibroid. And so this is a situation where it's causing problems. She has no pain. She has no, she's had a couple kids already, so fertility is not an issue. And so, but we're going to do the evaluation. And so, with anybody, you take the history, you talk to them. Again, you said, well, is this bleeding that happens during the time of the period? Well, one of the first things as gynecologists we're always talking about is, especially younger women, tell us about your period. Is it every month? Roughly every month? How heavy it is? How many tampons do you change? Do you have to get up at night to change them, etc.? Mm-hmm. These are basic things. One of the first questions I also ask, too, is do you bleed in between periods? Not supposed to. A little spotting with ovulation is okay, but if you have significant bleeding between periods, not normal.
Right.
You got to figure it out. And you ask, well, do you have pain? Do you have pressure? Do you have pain with intercourse, pain with sex? These are all things that can suggest a fibroid or some other pathology. And so what do you do next? Almost invariably, the next thing you do is a pelvic ultrasound. Pelvic ultrasounds are relatively inexpensive. They don't tend to be painful. There's no risk to them. They give you a huge amount of information. And in this woman that I'm talking about, I imagine we're going to find a fibroid. And the question is, where is it? Now, my guess would be on the inside of the uterine cavity, because if it was in the muscle, usually it may not cause bleeding. Mm-hmm. Certainly on the outside of the muscle, or on the outside of the uterus, it wouldn't cause bleeding generally. It's probably more on the inside of distorting the cavity.
So size and location kind of matter here.
Right, exactly. Okay. Location more than size, especially when it comes to bleeding and fertility.
Okay.
And so, again, so this would be a situation where somebody was bleeding. We got to figure out what it is. I imagine it's probably going to be a fibroid. Another thing, I've had people come in just saying they feel like they've got this, pressure pushing on their rectum. Like they just feel like they have to go to the bathroom. They have a bowel movement all the time. Or they feel like they have to urinate all the time because they've got a big old, softball pushing on their bladder all the time. Ultrasound confirms what we need to find. The other situation would be a situation where a couple's trying to get pregnant. And as part of that evaluation, we make sure the uterine cavity looks normal. We make sure the tubes are open. And on those ultrasound evaluations, sometimes we can find that indeed there's a fibroid that's inside the uterine cavity. It's distorting the shape of it. Sometimes it can even block the tube. I had somebody about 2 weeks ago with a 3-centimeter fibroid. She was young, otherwise healthy, had no other symptoms except she was having trouble getting pregnant. Mm-hmm. And we found that, and we're going to take it out.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure. OBGYN West provides exceptional care for women.
So once you figure out what it is and where it is, then the decision is, what do you do about it?
Right.
And so again, it comes down to a few basic questions. And the thing I ask people basically pretty much about whatever they come in to see me about is, what is our goal here? Because there have been times when I know there's some sort of condition going on, but it doesn't cause any pain. In which case, you may not need to do anything.
Right.
You might just follow it. We call that watchful waiting. Don't you love that?
Indeed.
Let's engage in some watchful waiting, shall we? And
you get to charge money for that.
You get to charge money for that.
I'm just putting that out there. You get to charge money for that.
That'd be level too.
It's nice to be a doctor. I mean, I do watchful waiting with my kids all the time. Nobody pays me for that.
That's right. But you get the blessings of motherhood.
I have teenagers. There's no blessings
now. But so, the question that, to go back to it, is that there's always the option of doing nothing.
Yeah, absolutely.
And that is a very reasonable thing to do if somebody, fibroids are not cancer. Let me just tell you that. They are not.
You know what? That's actually a really good thing to point out.
They're benign, smooth muscle tumors. And so, people obviously get very worried about a uterine cancer, and there is a muscle cancer called a sarcoma, which is a form of cancer that involves muscle and connective tissue. Mm-hmm. They're incredibly rare, probably on the order of 1 in 1,000 or less. However, in women who are having fibroid surgery, let's say you think it's a fibroid, they've got a mass on their ultrasound, and you go in and remove that fibroid. the incidence is, well, it varies from, it might be 1 in 400 or 1 in 500, and some studies have even shown more than that.
Okay.
And so you got to be careful about that, and that's one of the decisions you make when you are trying to decide what to do.
Mm-hmm.
And so, again, what is our goal? Are we trying to relieve pain? Well, if fertility is not an issue, you've got a mass in the uterus and it's causing pain or pressure, well, there's, like many things, there's medical and there's surgical treatment for these things. Medical things I'm going to say this tend because it's a little fuzzy because,
right.
But generally estrogen tends to kind of stimulate fibroid growth, whereas lowering estrogen tends to shrink them.
Oh.
Yeah. And progesterone, one of the other main female hormones, also has been sort of implicated in fibroid growth. And so dropping hormone levels can be helpful, except people don't like having their hormones dropped.
Right. I was going to say, what if you're like a younger or middle-aged woman, you've got fibroids,
right? So
you think dropping the hormones will help, but what if they're still in childbearing years and they want to be able to get pregnant? Wouldn't that impact things?
Exactly. And most of these things tend to be temporary. So while you're on them, they may help, but if you stop them, then the fibroids can grow.
Oh.
And so in the case of pain or a mass, not worrying about fertility, there's a couple things. We could put somebody on hormonal suppression or medical suppression with birth control pills. There are things that can drop estrogen levels basically to zero, put people in kind of temporary menopausal states, which can shrink fibroids by sometimes 50%.
Oh, wow.
But that tends to be temporary. But sometimes you do that if you want to try to remove the fibroid surgically, and you want to try to shrink it down before you do it, so you can perhaps do it laparoscopically as opposed to a big incision.
Okay, I get that.
And again, surgically, you can just cut it out, leaving the uterus in place if the person wants to have further pregnancies. And so, the question is, which is somewhat debatable, if somebody has, for example, fibroids and they are not going to have any more kids, and it's symptomatic enough, do you do a hysterectomy versus taking the fibroid out in and of itself? And most people believe that there's a pretty good argument to make about taking the uterus out and doing a hysterectomy.
Why? Because if you leave the uterus and just remove them, they can grow again. So they can sort of be a recurrent problem as opposed to eliminating the entire problem.
Yes, exactly. And so, because a lot of times there can be little baby fibroids.
Oh.
That can sometimes be microscopic and will just grow. And also, removing the fibroid in and of itself, leaving the uterus in place, is actually a harder procedure. It tends to be bloodier, and because they tend to have a big blood supply and can cause some post-operative issues. They're more likely to cause scarring and what we call adhesions.
Mm-hmm.
And so, if and this is obviously, I'm not somebody, and I think most of us are moving in the direction of not doing hysterectomies unless we really need to do them.
Okay.
But this is one situation where, if you have somebody who's 45 years old and they got a big fibroid and they're not going to have any more kids, if you took 100 gynecologists who were really well-intentioned, you'd probably find most of them would be pretty inclined to think that the best thing to do would be to remove the uterus in and of itself.
Oh.
Now, the other thing you can do is what's called a uterine artery embolization. And this is a procedure that is done by interventional radiologists, and they go and they basically put a little catheter in your femoral artery in your groin, just like if you were to have an evaluation of your heart or something like that. Angiography, they put in a little catheter through your groin, they feed it into the arteries going to the uterus, and they can actually block arterial blood supply to the fibroids themselves. And it can be incredibly effective. It drops the size, sometimes 50%, maybe even more. And so if it is just an issue of size and pressure and bleeding too, this can be very helpful. And you don't have to have a surgery, and it's associated, issues with possible more complications and being in the hospital. But it's not suggested. If you want to get pregnant, that is not generally recommended.
Okay.
So if you have a fibroid that's symptomatic, bleeding, or pressure, or impinging on uterine cavity or the tube, uterine artery embolization is not generally suggested. That's when removing the fibroid is suggested.
Okay. So there's options.
Right. And so, that's for more of kind of a bulk, what we call bulk-related symptoms. Just you've got a mass that's pushing on things. So medications can sometimes be helpful, and removing the fibroid can be helpful. Actually, removing the uterus in the form of a hysterectomy is ultimately helpful, and uterine artery embolization is another option. There are some other forms of procedures that are more kind of investigational. There was an MRI-focused ultrasound procedure where basically it was like Star Wars, where they'd use ultrasound and using an MRI focus this thing on the fibroids and zap them and heat them up and try to kill them.
Like the Death Star.
Yeah, exactly. It's just like the Death Star. But it hasn't been has not had huge acceptance because it's very expensive and it's the technology. Yeah, and
some healthcare, some health procedure is expensive.
Yeah, and it just and it's just the science behind it is not quite as.
So it needs some more cooking.
Yeah, it's not for prime time, although it's been waiting for prime time for about a decade. So I don't know if we're ever going to get there.
Okay.
But that's another thing to at least consider. And then there's some other things people are looking at, like freezing them or burning them and that sort of thing.
Oh.
Lots of fun stuff.
Indeed.
So then let's talk about the idea of bleeding. Now, we talked about kind of bulk-related symptoms, something pushing on something. The other main complaint people have is bleeding, and usually that's because the fibroid, the muscle tumor, is either located on the inside of the fibroid, on the inside of the muscle, the inside of the uterus.
Okay. Woo, there we go. We got it.
And in those situations, oftentimes we can actually put a camera through the cervix and shave that, so into the uterine cavity. Through the vagina, through the cervix, we put this camera, and through this camera we can put little instruments that we can cut and shave that fibroid away, and remove it. And it can take 15 minutes, it can take an hour, and it's an outpatient surgery. And the person goes home, they do great. It's an amazing procedure, and there's no incisions. So that would be the situation where it was on the inside of the uterine cavity. And that can be very effective. If it's in the muscle wall, it can be sometimes just like in the situation of a bulk related fibroid, something big and causing pressure. If it's in the middle of the muscle and it's causing bleeding, oftentimes we'll either have to talk about doing a hysterectomy or doing uterine artery embolization, or cutting out that fibroid in the form of a myomectomy, which is what I was talking about before.
Right.
And that can oftentimes be, depending on how big it is, it can be done laparoscopically or robotically. Sometimes we have to make an incision to remove the fibroid. The big thing that you may have heard about in the news in the last few years, there was some concern about this issue of cancer, of sarcomas. Because there was a case of actually, I think this was like maybe 4 years ago, of a doctor actually on the East Coast who had a fibroid, what they thought was a fibroid. They took it out, and what we would do is we'd laparoscopically remove this fibroid, and then inside the abdomen, what we call morcellate it, which is chop it up into little bits so we can pull it out.
Yeah.
Because the big thing about minimally invasive and laparoscopic surgery is, how do you get big things out of small holes? Well, you cut it up into little pieces.
Just like how you eat an elephant, one bite at a time.
You got it. Never thought of that. So
that's why I'm here.
Yeah. And so the problem was that it's an incredibly effective surgery, very slick, but in this particular situation, the pathology showed she had a sarcoma, which is a muscle tumor. And when you cut into muscle, into little pieces, you're basically spreading the tumor and the cancer.
Oh, no.
And so, unfortunately, she recently, actually, I believe in the last couple of months, actually died.
Oh.
And so was kind of a shakeup for the whole community. And, a lot of times the equipment in the past few years, much of the equipment that we use to morcellate, to cut things, actually came off the market because it got to be kind of political, and the
at this point, it only takes one thing going really wrong before you kind of have to bring everything to an all stop to an extent.
Precisely, and so everybody stopped doing the procedure, and it was really unfortunate because then everybody started going back and making big incisions and that sort of thing, and there's obviously complications related to that,
right,
and disability related to that, and you're going to be in the hospital a lot longer. And the unfortunate thing this is the really unfortunate thing, is that sarcomas, which are smooth muscle cancers, or cancers of the muscle of the uterus, the long-term prognosis is extraordinarily low.
Oh.
And whether you cut it up or not.
Yeah.
And so it really kind of took out some technology that was very helpful for us. But that's something we need to be aware of all the time. And so now we're doing things like taking the fibroid out and putting it into a bag inside the abdomen, and then cutting it up into little pieces in the bag, and then pulling the bag out.
Oh.
And so there's ways that we're kind of getting around that, so we can continue to do this minimally invasively without having to cut things,
yeah, absolutely,
make a big incision. And so that technology is available. You need to have somebody who does a lot of them and has done them for a long time. But again, there's also options for, again, if you're not trying to get pregnant, if it's just a matter of bleeding, for example, the uterine artery embolization procedure can be very helpful for those without having to make any incisions at all.
Mm-hmm.
And again, some medications can be helpful in terms of reducing bleeding that require no surgery at all, and including things like, ibuprofen, anti-inflammatories, which can sometimes decrease bleeding if you take them at the right time. There's other medications that we use that can affect the clotting cascade, our ability of our blood to clot, and can affect that we can give people during their period, which can decrease bleeding. So there's a number of different things that we can use to help that don't necessarily require surgery. So, but again, oftentimes if they're big enough and the symptoms are severe enough, we may have to consider surgical treatment or the uterine artery embolization. So the final thing is infertility. If you have fibroids that are on the inside of your uterus, as we were talking about, we saw this patient a couple weeks ago. She was young. She was otherwise healthy. No other reason why she couldn't get pregnant. Mm-hmm. On our evaluation, we found that she had a big fibroid on the inside of her uterus, and we are now going to take that out using the hysteroscope, a little camera that goes through the cervix, and we'll shave that thing out, and she will get pregnant. And so that's one option for that. Again, if the fibroid is in other places in the uterus, depending on the location, as we were talking about with the other symptoms that fibroids can cause, we sometimes have to make an incision, but oftentimes can do these with minimally invasive procedures. The one thing that is not suggested at this point for women who are trying to get pregnant is the uterine artery embolization that I've talked about.
Right.
And so if you are still wanting to preserve your uterus and you want to get pregnant, that's not generally recommended, and removal of the fibroid itself, one way or the other, is suggested.
Okay. Makes sense to me.
Yeah. And so the point, again, is that these fibroids are incredibly common. 10 to 50% of women have them. And again, the other thing is you don't have to do something just because a lot of people find out they have fibroids for incidental reasons. They're getting an ultrasound for another reason. They find out they've got fibroids,
right.
or their physician just notices on examination that the uterus is enlarged. They do an ultrasound. They find out they're fibroids, but they don't have any pain. They're not bleeding. They're not no issues with trying to get pregnant. You don't have to do anything about it. They could be the size of a watermelon. And what tends to happen is that when a woman goes through menopause and her hormone levels drop, the fibroids are very responsive to estrogen and progesterone, and they tend to shrink on their own, although not all the time.
Right.
And so there are things that can be done. Oftentimes, these are minimally invasive ways of managing these conditions. And so get in to see somebody who knows what they're doing. Don't suffer. That's my motto. Don't suffer.
I agree.
All right. There it is.
That's all we got. There is the landscape.
There's the landscape.
As always, if you have questions, comments, you want more information, go to Facebook. Go to the GynoCast Facebook page. We told you earlier how to get to it. Just hit the search bar and put in the GynoCast. And if you're a member, you should just be able to click on the sidebar on your homepage at Facebook. If you're not, just request to be a member. We have great conversations. Easy. You can send us your questions there through the Send Message tab. Mm-hmm. And you can jump into the discussions that we're having there. We have lots of great discussions. And as always, anything we talk about in the GynoCast, we will put in the syllabus. The syllabus will be available at the Facebook page at the GynoCast. It will also be available at the Matriarch Digital Media website. That's matriarchdm.com. Don't worry, there's a link at the GynoCast Facebook page. You can just click right through it. And as always, we appreciate you listening.
Thank you. See you soon.